So what's in store for 2013-14? And I know a lot of you are very anxious to hear where we go from here. So, year one, a successful transition process. We're all getting the hang of it. What's next? Just to give you a taste, and these numbers have gone out to districts. We're in the process of discussion and negotiation about them. We're using the 5-year linear extrapolation, which we used this year, but we're also adding to that weightings against weighted population change, unplanned readmission rates, preventable hospitalisation, relative utilisation rates and health need index, which brings in equity and access considerations. So there's specific adjustment weighting factors on purchasing volume increases, and then also additional considerations in negotiation with districts. We'll be looking at inter-district and cross-border flows and specific capacity changes. So if you've got a whole new service where a new capital facility has been built, then we'll be obviously purchasing the services to populate that too. I won't go through the detail of all of them, but a similar approach with a more refined approach on ED. And with mental health and subacute, I won't go into the technical detail now, but they're essentially the ABF basis of both of those and mental health's an interim model. The subacute is based on the New South Wales developed SNAP model, is more bed day based. And so therefore you're really funding capacity. And so that forms the base of the funding, and then we're allocating growth according to where we're purchasing new capacity. So to the extent we're opening new subacute units in the forthcoming year, new mental health units, we will explicitly purchase using the new model. Non-admitted, still the most difficult area, but we've made huge strides in the last 10 months of improving the data. We've created a conversion ratio to move between our occasions of service model and service events by district, because every district sort of has a different array and way of doing things. And where we can, we're looking at a weighted population growth to patient level data. But again, this is an area where we're proceeding with extreme caution until we get the data better. But as we're finding, the more you use the data, the better it gets. So just to conclude, the New South Wales funding model is about a lot more than activity-based funding, and it's not an end in itself, the most important message. The power is in its transparency of resource allocation and performance of the health service in delivering patient outcomes. It critically underpins and provides a great platform for the things we want to move forward on, and which will be articulated in the middle of this year in the state plan, which has been undergoing a state health plan, which has been undergoing a widespread consultation process around the state. Supporting our devolution agenda, which again is not just a philosophy, it's about better patient care being able to be organised locally, and strategic resource allocation, as I say, to design and deliver the health system we need for the 21st century.
So what is National Health Reform? Well, there's a document called the National Health Reform Agreement, which has a number of components, not only about activity-based funding. And it says that the Commonwealth and the states will work in partnership. Partnership is an interesting word. Still a little bit of a work in progress, I think, in Australia, in terms of the relationship between the Commonwealth and the states. And they're aiming for a nationally unified and locally controlled health system. Very important concepts, and again, Mary has spoken about the need for local responsibility and local autonomy and the ability to change and adapt to local needs. From a hospital and local health network perspective, there are two main changes in terms of national agenda, transparency that Mary's spoken about, and changing the incentives. And the change incentives are of two kinds. First, there are changed incentives on the Commonwealth, and this is actually, I think, particularly important, and particularly important for the long term. Post-2014, the Commonwealth shares in the cost of hospital activity growth. This is the first time this has happened. And so rather than just saying, look, we don't really care, it's up to the states, prior to July 2014, the states bore the full marginal cost of any additional hospital activity in this country. Post-2014, the Commonwealth will share 45% of the cost of growth. Have the hospitals been able to adopt, have the local hospital networks been able to adapt and make sure they've got the management capacity to work in the new system rather than the old shades of grey system that Mary showed you where different skills are necessary? Have local clinical engagement strategies been appropriately developed? Are they all in place? Because with an activity-based funding environment, you need to have both the clinicians and the managers talking together and working together to address the issues on that right side of that spectrum I showed about cost per day and days per stay. And 2014-15, obviously the additional Commonwealth funds will flow, and hopefully there won't be the question marks that I've put on the 2013 about management competencies and local engagement strategies.
As we all know, funding reform per se does not improve patient care. We must develop and, most importantly, implement best practice models of care across the New South Wales health system. We must provide quality health care for the people of New South Wales across all the dimensions of care, some of which have been said but not defined today, of access, appropriateness, effectiveness, efficiency, safety and consumer involvement. And most important, we must address unwarranted clinical variation. If there are appropriate, flexible and transparent funding arrangements, then providing both the right incentives and disincentives in financial terms to provide, as the Minister said, our very brave Minister who is keen to address all these, to provide the right care in the right place at the right time, to which I'd add the first time. Then funding reform can, like information technology, be one of the enablers to achieve improved patient care. As with every other field of business, every other deal I've been involved with, both quality and efficiency are measures of their achievement. You don't have one without the other. So what does this all really mean? As Dr. Foley said, it cannot be just as simple as activity-based funding that Captain Case Mix would have you believe. We must all remember that Case Mix was introduced as a utilisation and efficiency tool, not a funding tool. I well remember the initial heady days on the Australian Case Mix Clinical Committee when we developed the Australian National DRGs, and subsequent modifications have now passed into it being used as a funding mechanism and, as has been mentioned earlier, bought by other facilities. We're all familiar with uncapped case mix-based funding and the wrong financial incentives provided in such a model, and I am concerned with what I've heard so far that some of that's still there. Reward for admission and doing something, do anything. Down in Victoria under Captain Case Mix, you just thought of a reason to bring patients into hospital and do something to them to get rewarded. We require in New South Wales to learn from their errors and have a much more sophisticated, appropriate, flexible and transparent funding arrangements, because the correct financial incentive in many conditions should be to make it you don't admit the patient, because you get a safer, more effective and more efficient healthcare for that cohort of patients.
Our products are a single national efficient price for activity-based funded hospital services. And in 2012-13, this covered acute inpatients using DRGs, emergency department services using urgency-related groups, URGs, and outpatient services using Tier 2. And from 1 July this year, we've priced services for subacute and admitted mental health, which is sort of the next step in our evolution. The national efficient price for 13-14 we released at the beginning of March and will be $4,993, which is a 3.8% increase on last year. There have been questions, I guess, around national consistency, and significant improvements have been made on that over the last 3 years. We still have challenges in coverage outside of ED and admitted patients, but there's significant work underway that no doubt many of you will be involved in over the next few months to improve the costing, particularly in outpatients and mental health, and as we move into non-hospital located services, community delivered services, that's a big challenge for us as well. 'Cause,
So there are challenges in the new funding arrangements. I think nobody would dispute that. What I'm going to talk about is how the Northern Sydney local health districts have responded to these challenges, and in particular give you a board perspective on what we see as our challenge and then how we're actually making progress against them. So it has been interesting for the board and the executive together to develop the service and performance agreement. Previously we were given our service agreement, and I think activity-based funding being retrofitted into the budget has also been a challenge. Understanding and communicating to our broader clinical and management teams the rationale behind the nationally efficient price and then how that gets translated into the state efficient price hasn't been easy, and for people to understand how coding and translates into a nationally weighted activity unit, and the issue about how separations and cost weights interact has actually been quite challenging for the board, who largely are made up of non-medical people, to actually understand. It doesn't easily translate into commercial terms when you think of funding. And I think one of our challenges, as was pointed out this morning, has been very cultural. I think our staff in particular have been very used to going and talking to the minister and the ministry, and I think there has been an expectation that, well, look, you know, what can we do? We can't stop them coming, therefore the ministry will just have to stump up and give us more money and bail us out. So we do have a resistance to changing the models of care, and we do have a resistance to adopting what is seen as best practice if this is how somebody has always done it. So they're my 3 slides of challenges, and that's very much truncated.
So what does it mean? We've heard about the 4 R's, and we also heard today, you know, about right care, right place, right time, right person the first time that Brian said. I think we need to include the right price. We have an understanding of what a COPD admission costs us, and we know the variance that it costs. But do we know what it really costs to treat that COPD admission in a hospital in the home environment, or to work with general practice and other providers in the primary care to get a better, an equal or better outcome? But what does it really cost us? And I don't think we really know that yet, and I don't think we're really at the point, but we need to get there quickly to understand what those costs are so we can make smarter decisions about investment and or disinvestment. Key players, we've mentioned it before and we've heard it this morning, patients and their carers, and I guess we all agree here today that patients and carers are absolutely at the top of that. And I guess it's going to be really interesting to look at the NDIS and how that rolls out, and I think we'll get a lot of learnings from that. So admissions trading scheme, that interface between the acute sector and the primary care sector. We need to understand a price on admission, and we know in our service agreements we've actually got incentives to reduce readmission rates within 28 days. And if you start unpacking that data, it gives you very interesting information about what we need to do to be more efficient. But what are we actually going to buy from the primary care sector, and do we do that locally? Do we do it internally, or do we actually go out to the marketplace? We need to do it on a contract management basis. There needs to be a strong business platform and model for us to know what we're purchasing.
The challenge for us in the health system then, in this day and age, how do we position activity-based funding in all the, I guess, responsibilities we have in delivering services at the local activity? It's a really complex soup of initiatives that we're grappling with. Activity-based funding sits somewhere in the middle. The 3 T's that I chose just quickly to briefly mention, the macro, meso and micro, but I think we were well informed of the macro level intervention in this morning's presentations when we looked at it in terms of the national and the state agenda. But I've lowered it a little bit to the network, facility and patient level. And I think it looks subtly different at every level, and the understanding, the knowledge that people need to have varies at each of those levels. In an attempt to continue to reiterate the quality and ABF nexus, We're doing some work with coders on the Between the Flags initiative and coding. Also, we've got to make it easier and simplify how we do. So we're going from paper-based coding queries to electronic. The relationship with finance changes dramatically under ABF, and we've gone on a journey of changing the way budgets are allocated to departments and subspecialties. At the patient level, the relationship between inputs and quality of outcomes should be at the forefront, and our decision-making must be based on best clinical outcomes. I would emphasise we need to ensure that we do not compromise the quality of care with understanding some of these cost perversions. We must not be reluctant to move to new models of care based on where we see better return on investment. The model and quality of care should always take precedent.
There are 3 priorities for the next 12 months. We had a great group, great discussion. A lot of discussion was what was the second wave of devolution, and when did the first wave really start, and when did it start? And it does mean different things to different people. And it was a really important discussion. An important 3 issues that we raised with the group was the need for improved information at the patient decision-making level in a timely manner. This is the journey we're on. There is a lot of information. I don't think any of us would put our hand to heart and say that we've got it all right, especially the decision making, but also at the coalface. Have we got the right information to allow those critical decisions that allows us to use ABF and other mechanisms to improve evidence-based outcomes in care? So it was a really important issue.
There was a lot of commonality in the end in terms of the feedback that brought us to these 3 priorities. There was clearly a need from what everyone was talking about to get better communication and connections between the elements of the system around improving care for patients, and that needs to be supported by IT. There's a lot of discussion about a lot of the IT at the moment is siloed because it doesn't link and doesn't support patient care across those boundaries or interfaces. And there was another point that, to achieve real improvements, we need to define the pathways for care that are being then supported by the communication and the IT system. So that was a sort of first priority area for action.
But we had some really good conversations. One of the things we did talk about in the earlier slide about just get on and do it was that perhaps the time for talking about this reform was over, and it was time that we get on and do it. And there seemed to be strong support for doing that. In terms of the performance framework, it was felt that we need to amplify the quality and safety indicators, and that perhaps even though we certainly measure more than just finance, and that it was felt that there needs to be more energy on the quality and safety and agenda. So that's something that we need to take away and have a look at.
The final three things we came up with were that we had to actually put up a business plan. So you had to actually look at the evidence for this. You had to identify the sites that might best be suited to this, and you had to go through a clinical redesign process. We also needed to look at the sites where this was already in place, and admittedly that's very limited, although it's growing. And we need to look at those sites and evaluate them, and the evidence for outcomes needs to be available to everyone, which may help to drive the process as well. So we need to both look at the sites that are already doing it and identify sites and champions at those sites who are likely to be able to lead the push for this to be expanded in their sites.
I guess in terms of the health system first, before we move outside the health system, one of the most important things we talked about was the importance of providing, we talked about data to start with. And in the end, we've actually used the word information. And that's really been through discussion that we're actually a very data-rich environment, but we haven't created, or we haven't taken the opportunity to turn that data into sensible information that we can do something with. So we talked about providing credible information in a timely manner that is verified, that the clinicians actually believe is correct. And to do that, actually, we're saying that there should be early clinician involvement in that process, and very much what Gabriel's saying around clinical leadership. So that partnership between managers and clinicians moving that agenda forward.
I think that it's clear we've put a lot of the mechanics and the support structures in place now, and we're really poised to say, okay, we've done the hard yards on that. What can we really do with this now? And I think the conversation has really highlighted how we can invest and disinvest in the right kinds of care to have the health system we know that we want and need to develop.